Hi, welcome to Health Focus. I'm Ann Rodriguez, your host. Health Focus is brought to you by HCA, the Hospital Corporation of Virginia. We'll talk a little bit more about HCA and what they bring to you, but more importantly, what they bring to you today is a wonderful opportunity to talk to health professionals about issues that may affect you, making us all smarter in terms of preventive work or in treating diagnoses. And we're going to talk to Dr. Gary Spivack today. In fact, this is backed by popular demand, Dr. Spivack.
Yes, thank you very much.
We talked with you, I can't remember, but it's
right. A few months ago.
Sometime in the past year.
Right.
You are a child psychiatrist, and we'll talk a little bit about what that means. Just by way of introduction, you are the founder and director of Columbia Associates in Psychiatry. That's located here in Arlington, Virginia.
Right.
A full practice.
And we also have offices in Loudoun, as well as actually up in Bethesda and Silver Spring.
All over the region.
Right.
You're also the clinical director at Dominion Hospital, which is an HCA facility here in Northern Virginia. And that's a hospital with beds that is able to do in-treatment for people
right.
with...
Exactly. We have both inpatient and day hospital programs.
And then you also are the founder and medical director of MindShape, which is about behavioral medicine.
Exactly, where we apply the same principles of understanding people, but to help people with medical conditions such as losing weight, hypertension, prediabetes, etc.
You're a busy guy.
Very busy.
Our subject today, and we're so delighted because we're going to have you with us the full half hour, talking about children and adolescents and mental disorders. To just set the stage for us, talk about generally your practice, what you see here.
Well, what we see here is really two of the most common difficulties that come up in children is anxiety and depression. And I think that happens mostly with child psychiatrists, where the other big disorder in childhood being attention deficit disorder, and mostly pediatricians see those when they're uncomplicated. But when they go along with some of the other disorders, we end up seeing them as well. And
anxiety and depression, we're not used to talking about that in children and adolescents. Certainly maybe in the last 10 years we've become more aware.
Exactly. Those very same disorders that occur in adulthood, we've realized over time almost always start in childhood. We used to think that really children had nothing to be worried about, nothing to be depressed about, but we found out really very much to the contrary, that a lot particularly of them have to do with your early childhood and also just biologic, what you inherit from your family, so that the anxiety disorders that begin in childhood often go right into adulthood. And the same with depression. It's a little bit different with the boys and the girls, in that with the girls, the depression tends to really go up when puberty starts. With the boys, it's more before.
Is some of this, you know, hardwired? Or more situational, or is it your work to try to figure out what it is?
Exactly, and it's pretty much always both. That the whole medical model of illness is that you have a vulnerability, usually that you inherit, and then depending upon the level of stress and the level of support you have, you may or may not develop the illness.
And it's all about how it gets manifested, that's behavior, and so many of us feel like we're real experts in that, and indeed we're not.
Right. I mean, it is difficult because a lot of what we feel intuitively in childhood, it really looks different than it does in adulthood. It's understanding how it's different with each developmental phase, what's different in preschool, in the early school years, in adolescence. We can see the same disorder showing in different behaviors.
And these are behaviors that are beyond a kind of a terrible 2 or beyond a precocious 8-year-old. We're really talking about disorders that need to be treated with someone of your capability.
Exactly, and the reason for treatment, because they are beyond normal, and many times these are biologic illnesses, is actually to try to prevent them from existing in adulthood. And that's really the focus of child psychiatry, is to get development back on track, back to normal, so that there's as little damage as possible from these disorders, and then maybe they simply won't exist when the person is an adult.
Is an adult, because if these go undiagnosed and untreated, then it's a very difficult situation when you reach adulthood.
Absolutely, and particularly before adolescence, when you're forming your identity. We find that if we can really work with kids before they become adolescents, we really form what's called a therapeutic alliance with them, to work together. And that when they're feeling better about themselves, we can avoid a lot of the issues in adolescence, particularly drug abuse, promiscuity, et cetera, that are manifestations then that are harder to deal with because the adolescent feels like you're trying to take themselves away from them.
And we're going to talk a little bit later about self-injury and also eating disorders in adolescence too. I had asked before we went on camera, how young could someone be and be diagnosed? And you said in the womb. So talk a little bit about all of those early stages that are set.
And again, it wasn't as much diagnosis in the womb as it is what's the early that we could actually treat someone or help someone. And I mentioned to you, because we're really dealing not with just the child, but a child and the people taking care of the child.
The unit.
Exactly.
Whatever that might be.
Right. And for an infant, it's really important that the mother be in good emotional health. And particularly, you know, in pregnancy and then right after pregnancy, because postpartum depression has a very powerful effect on the infant for really the infant's whole life, even into adulthood.
Because those early days and weeks and months are really, that's a time that you bond, and stop me if I'm using inappropriate language, but if a woman is going through severe severe postpartum depression, yes, that mother could be literally absent from that infant's life.
But it doesn't take severe, it just has, you know, any kind of postpartum depression that really is clinical. You know, we're talking about something that's more than fleeting. Yes, it has a dramatic impact just because of the bonding, because the baby's totally dependent on signaling for the mother. It really looks to the mother to develop. It is a unit, and so when part of the unit's not working, the other part's not developing.
What are the statistics on postpartum depression? What statistically are there any? Is there information about the people affected, the number?
Well, yeah, I don't have an exact number. What we do know is very much undiagnosed. We know that depression in and of itself at any time may be running in 5 or 10% of people, and that's a time that people are very vulnerable to it. And so it becomes important for people to be screened for it from a public health perspective, whether it's by their OBGYN or by the pediatrician, so that they can really get proper referral and treatment.
How young would a patient be and find the family in your offices?
Mostly people come into the office starting about 5 or 6.
Okay.
We've worked a lot with preschools on a consultation basis, where we really help the preschools, really help the parents to do the best with the children. But it's hard for people to begin to even think about a child earlier than that having a disorder.
And you talk too about one of the difficulties at this age is all of us taking parenting so seriously, manifestations that are unusual, behavior that's unusual. The first reaction is to have it reflect on you as a parent and talk about an important role that we're given, some people feel lightly, but this role that we have as a parent.
Right, and that's true. We feel it's a reflection upon us, and in a lot of ways that's positive, because that leads us to then want it to be a very positive reflection upon ourselves.
And get help if needed.
Right,
yeah.
And we place an emphasis as child psychiatrists on prevention and resiliency. So we're looking at it not as a mark against you for coming in, but really a mark for you, much as it would be if you took your child to the dentist, to make sure that development is really happening appropriately. And so you can build resilience, have your child be less likely to develop